All right, everybody, we're going to go ahead and cover our endocrine system chapter next. See if it'll let me go on. There, sorry. Okay, so these cases won't mean much to you looking at them now, but what I want you to do for now is review each of these four cases. If there's any words that you're not sure about, try to use your new lists and old lists to define some of those words that are our medical terms. And I want you to keep these in mind as we're talking about our different systems or glands within the endocrine system and see if you can kind of figure out which is responsible for the dysfunction going on in each case. So pause your video for now, take a quick read, define some words, and then we will revisit these at the very end. So our endocrine system is a collection of different glands, some organs like our pancreas and our thymus and thyroid, but for the most part, they are glands like our adrenals, the pituitary, the pineal, and so they contain hormones. So these are endocrine, meaning that the hormones are going to go directly into the bloodstream. If you remember back from our integumentary system lecture, we talked about both endocrine and exocrine glands. So the main difference there is that an exocrine gland is going to release into some kind of opening that will carry it to its target, whether that be the blood or the surface, but endocrine is going to go directly into the bloodstream. So hormones are our other messaging system outside of the nervous system. We talked about the nervous system being similar to kind of the electrical wiring within our bodies. Hormones also communicate or cause changes in the body, but this happens on a wider scale. So it typically affects the whole system rather than just one specific area with our nerves. And these are going to be longer lasting effect. For example, if I tell my biceps to flex my elbow, when I do that, my forearm comes right up. It only affects that biceps. It happens right away. Hormones is not quite that simple. There's target tissues that are spread throughout the body that have receptors for specific hormones, but that hormone not only has to enter the bloodstream, it has to travel to the target tissue, and then that effect actually has to take place within the target tissue and oftentimes multiple target tissues. So much slower messaging system than our brains. All right, so we have both local and distant messengers. The local ones we call paracrine. We're not going to talk about that too much more. The distant ones, we're going to talk about endocrine. So this is a very simplified diagram of what happens with your hormones in the blood system. More or less, we have our hormone represented by our green dot. So think these are our secreting cell, meaning this contains the hormone or secretes our hormone. And then you can also see our target cell. So the green dot, our hormone is traveling directly into the bloodstream. And then when it reaches a tissue that contains target cells, that hormone is going to diffuse out of the bloodstream and land on its receptor. And you can see the target cell has a receptor that is shaped just for this specific hormone. So if we had a triangle versus a dot, then we would not fit in, so it's not going to affect that tissue. So hormones are going to only affect tissues that have receptors for that specific hormone. So we regulate homeostasis, or that balance in the body. Very much a large majority of that happens due to the effect of hormones. So as our body is constantly kind of taking account of what is going on, sugar levels, oxygen levels, calcium levels, all these different levels within our body for materials that we need. When those get a bit out of whack, we can secrete hormones to help bring them back in. So again, that negative feedback loop that we talked about way in the beginning, the concept of negative feedback loop is really, really important to the whole concept of our endocrine and hormonal system, because imbalances in that homeostasis oftentimes result in pathology or issues. Okay, our hypothalamus. So our endocrine system starts all the way up in the brain. We'll talk about the hypothalamus and our pituitary gland because they're very much related. So our hypothalamus is the primary link between the endocrine and nervous systems. So it's the link between our two messaging systems. And in the endocrine system, our hypothalamus's job is to control our pituitary gland. So I want you guys to kind of focus on this box here. We'll touch on diabetes insipidus, but this is what I want you to focus on. So these are all the different hormones that are released and produced by the hypothalamus. And you'll see a large group of these end in releasing hormone. So these releasing hormones have kind of sibling hormones located within the pituitary gland that are the actual hormones. So for example, thyrotropin releasing hormone triggers our pituitary gland to release thyrotropin hormone. So our hypothalamus has a lot of the releasing hormones. Those releasing hormones trigger our anterior pituitary gland to release the next hormone in the line. There's a few others that we'll touch on. Vasopressin and ADH and diabetes insipidus we'll touch on, but kind of the releasing hormones are what you should definitely know about the hypothalamus, and that it's going to control our pituitary and specifically the anterior pituitary. So our hypothalamus also produces a hormone known as vasopressin. So when it's produced in the central nervous system, we term it vasopressin. Typically, when it's out in our peripheral system, entered into the bloodstream, we're going to refer to it as antidiuretic hormone, or ADH. And so just to be clear, vasopressin and ADH are the same thing. So if we have a lack of vasopressin or ADH, that can cause a few issues, the main one being diabetes insipidus. So this isn't type 1 or type 2. Diabetes insipidus is a separate category of diabetes. Diabetes mellitus, we'll talk about later on when we talk about the pancreas. That is what you're thinking about with traditional diabetes, type 1, type 2. So diabetes insipidus is a lack of vasopressin or antidiuretic hormone. So if we break down antidiuretic, that will kind of tell us what the hormone does. So anti meaning opposite, diuretic means to release water. So if it's antidiuretic, that means it's going to tell our bodies to retain water. So if we don't have enough of this hormone, our body is going to be releasing more water than it should be. So these people tend to urinate a lot because that's one of the ways our body disposes of excess water. In this case, we don't necessarily have an excess, but we don't have the hormone telling us to retain it. And polydipsia, meaning they're thirsty all the time. So oftentimes these people are constantly sipping or drinking water, but it never seems to be helpful because they don't have a high enough level of vasopressin or antidiuretic hormone to actually help them retain and utilize that water. So that's diabetes insipidus. Okay, so the next step in the chain is our pituitary gland, which actually breaks into anterior and posterior. And so our anterior is what controls a lot of the body. So it's going to regulate our reproductive system. It's going to regulate metabolism. And so you'll notice that there's a couple other of our endocrine system organs and glands, like the thyroid, the adrenal, the ovaries, the testes. All of these are going to be influenced additionally by the anterior pituitary. So we sometimes term that the master gland just because it helps regulate some of our other endocrine glands. Our posterior pituitary only has a couple of hormones that are made in the hypothalamus, so it's kind of our storage center for that vasopressin or ADH, and it also stores oxytocin. We're not going to talk a lot about oxytocin, but it plays a role in childbirth. It helps strengthen our uterine contractions, and kind of fun fact, it's one of the few positive feedback loops that we see in the body for a good reason. So anterior is going to have a lot of those hormones that are kind of the next step from the releasing hormone. And then the posterior is the storage center for those other two hormones that the hypothalamus is making. So growth hormone is also known as somatotropin, and it does exactly what it sounds like. It's going to help us grow. Typically, in terms of pathology wise, we see an excess amount or too much growth hormone. So that can result in acromegaly, which means really enlarged extremities and bones. So your growth hormone continues to push the growth of bones past what might be considered normal. And then gigantism is just the pediatric version of acromegaly. Adrenocorticotropin hormone is going to stimulate our adrenal glands. So that's another gland that we will talk about. Thyroid stimulating hormone, again, is going to stimulate our thyroid gland. So it's going to affect the thyroid, which is primarily going to regulate our metabolism. And then we have melanocyte stimulating hormone from the integumentary system. If you remember that term, melanin, that is the pigmentation secreted by melanocytes that give our skin its pigment. Last stop in the brain before we move down into the body, we have the pineal gland. And so the pineal gland's job is to secrete melatonin. So don't get melatonin and melanin that we just talked about mixed up, because they have very different functions in the body. So melatonin is what helps us control our circadian rhythm. And really, it's the pineal gland that does that via secretion of melatonin. So it's very much affected by light. So in darker environments, our pineal gland will release more melatonin. In lighter environments, it's not quite as stimulated to secrete that melatonin. You sometimes hear people taking melatonin gummies or vitamins as supplements to that melatonin. Not a great idea to do that all the time because your body gets sensitized to it, but sometimes adding an extra punch can help you fall asleep. So that's our pineal gland. And that's why having a good bedtime routine actually makes a difference, eliminating light, not sitting on your phone, all that good stuff. Okay, thyroid and parathyroid is almost like two glands in one, because if you look down at the bottom right here, you can see those little yellow dots are the parathyroid glands that are sitting right on the surface of our thyroid gland. So they regulate metabolism. So we have hyperthyroidism if we're producing too much T3 and T4. That's the two hormones that our thyroid produces. We can get things like Graves' disease or thyrotoxicosis, meaning we're at a toxic level of that hormone. And then we can have hypothyroidism, kind of the opposite side of things, where we're not getting quite as much introduced into the system or enough introduced to the system, and our metabolism is going to suffer. The parathyroid gland, its main job is to regulate calcium. So it's definitely a good diagram here. This shows it pretty simplified. And so we're looking at whether it's high or low. We're typically going to work on this bottom half of our loop. So when calcium falls below its set point, we're going to have parathyroid hormone released by the parathyroid gland, and that will trigger us to pull some calcium from the bones, and our blood level will rise. Now, typically, if blood levels are getting back to normal or edging a little bit higher, we'll just slow down or stop the secretion of parathyroid hormone. If it gets way too high, that's when the thyroid gland will release calcitonin. So parathyroid gland with parathyroid hormone, that's the primary mechanism that we're going to use to maintain our blood calcium levels. If things get way out of whack, then the thyroid gland, not the parathyroid, but the thyroid will release calcitonin, and then that's going to pull blood, or sorry, not blood, but calcium from the blood to the bones. So as I said, we kind of go both ends of the spectrum with the thyroid gland itself. So we have hypothyroidism. Here's some of the key symptoms. You'll see there is a little bit of an overlap between the two, which is interesting since they're kind of the opposite of each other. And then hyperthyroidism, we have a lot of these. And so in general, our symptoms for hyperthyroidism are going to be related to our systems being a bit too jacked up, metabolism moving too quickly. Hypothyroidism is going to be systems slowing too far down, related to a decreased metabolism. Hypothyroidism is a bit easier to treat than hyperthyroidism. There's a medication known as synthyroid that more or less mimics that T3 and T4 hormone. And so if we can add fake thyroid hormone in, we can try to kind of bring it back to a normal level. Hyperthyroidism is a little bit trickier. Oftentimes they will have to do some type of procedure to destroy or remove a portion of that gland. And then oftentimes if they can't kind of get it right level, they'll even supplement with synthyroid if they've brought the levels too far down. So not always the easiest thing to treat. It's a bit of trial and error with those diseases. All right, our thymus gland, we talked about this in the immune system already, but it is located right between our lungs. Its main job in the body as a whole is to mature our T lymphocytes, our T cells. So remember, they start in the bone marrow with our B cells, but they are going to travel to the thymus where they are kind of matured and trained. And so thymosin, thymopoietin, and thymulin are all hormones that help us get to that end goal. So the thymus is in charge of T cell development and proliferation. That's the still main concept that we talked about in the immune system chapter. All right. You can see this cool picture of our kidneys here, and the purple triangles on top there, that is our adrenals. So our adrenal glands are split into two areas if you look at this cross section down here below. So a majority of it is our medulla, which is the middle portion, and then you have this thick kind of band of tissue around the medulla, which is the cortex. So our cortex is going to have a majority of our hormones. It's broken into a few different zones. That stuff I don't need you to know. I just want you to pay attention to the end result here, our actual hormones. So aldosterone, cortisol, corticosterone, cortisone, and then our last one is dihydroepiandrosterone. So you have a few different ones that are going to come from the cortex, and we have epinephrine and norepinephrine that are going to come from the medulla. So our cortex has a little wider variety of functions because we have multiple hormones. So aldosterone is really big in fluid balance. Cortisol, corticosterone, and cortisone are all steroids. They especially influence our glucose metabolism. And then our androgen in this last zone is going to be what stimulates the development of our secondary sex characteristics partly. Like I said, epinephrine and norepinephrine, that's going to stimulate our sympathetic autonomic nervous system. So we had, remember, parasympathetic was rest and digest. Sympathetic is our fight or flight. So epinephrine and norepinephrine are going to increase in our system when we're trying to go into fight or flight mode. All right, our pancreas. So this is where we get to our other part of diabetes. So we touched on diabetes insipidus in the beginning. Now we're going to talk about diabetes mellitus. So this is where type 1 and type 2 come into play. So our pancreas secretes two primary hormones that we're concerned with, insulin and glucagon. So insulin is going to facilitate glucose into the cells. So think insulin into the cell. So high blood glucose, we have plenty of sugar in our system. We just had a meal. Now we need to get that glucose, which is our usable form of sugar, into our body cells so they can actually use it for energy. So insulin is going to be the hormone that triggers that uptake of glucose. Glycogen is the stored form of glucose, so that is triggered by the hormone glucagon. So if we have too much glycogen, not enough sugar in the blood, low blood glucose, glucagon will be released. We can break down some of that glycogen, and that is going to add glucose to the bloodstream. So type 1 diabetes is the genetic side of things, And so they have a destruction of these beta cells that produce insulin. And so even though their insulin receptor is working just fine here in the cell, they're not producing enough insulin to actually get our body to take up enough sugar. Type 2, on the other hand, there's not as much insulin production. Our bodies have gotten too used to having a high blood glucose, so it doesn't trigger that same response. And the actual receptor is very resistant to insulin binding to it. So type 1 is genetic. Type 2, our bodies have gotten insulin resistant. We've had too much sugar in our blood for too long of a period, and so it's no longer producing the insulin response that we want it to. So the only ones that are different in male and female in terms of what we're going to talk about today is our gonadal glands. And so we have our ovaries and our testes. So the primary hormone for females is going to be progesterone and our estrogens. In males, it's going to be testosterone. And so that doesn't mean that females have no testosterone and males have no estrogen. It's just the primary hormone that's kind of driving the bus for those systems. So in females, our ovaries with the progesterone and estrogens are going to develop our female reproductive system, our secondary sex characteristics. It'll help regulate the menstrual cycle, and it'll also have a role in pregnancy maintenance and kind of the whole process of carrying a embryo. For testosterone, of course, it's going to be our male reproductive system. Same thing, our secondary sex characteristics, and it's very important in our sperm cell maturation. And then just remember the androgens that are coming from our adrenal cortex are also going to play a role in that secondary sex characteristic development. All right, here are our case studies again from the very beginning. So I'm going to give you kind of answers and steps here. So go ahead, take a look again and make your best guess on what system you think or what gland you think is the issue with each patient. All right, once you've made your guesses, go ahead on to the next slide. All right, so if one of these four at the top right was not your guess, then you are a little off. So now you have your four answers. See if you can actually match them to your patients. If you got them already, that's great. All right, so if you made your guesses, we'll go ahead and reveal. Okay, so hypothalamus for our first case. So we had an 8-year-old male, rapid onset obesity, lethargy, adiposia, meaning they're gaining a lot of weight, and temperature dysregulation. So temperature dysregulation was probably your biggest hint for hypothalamus. But in general, he had a kind of a wide range of symptoms. I think the hypothalamus controls a lot of our different hormones and controls the pituitary, which is our master gland. So that is going to affect multiple systems. Patient 2, 52-year-old man, subacute epigastralgia. So that means it hasn't been going on for long, but didn't just start, and he's got pain above the stomach. Jaundice is a yellowing of the skin. Polyuria, that means we're producing too much urine. And then ketonuria is going to be ketones or a product of fat metabolism in his urine. Polydipsia means he's also very thirsty. His fasting plasma glucose test was suggestive of glucose intolerance. So glucose intolerance and all these issues with glucose is going to be our pancreas. 64-year-old postmenopausal woman is cold, restless, has myasthenia, meaning muscle weakness, and excess abdominal fat. Lab results showed hypercholesterolemia. So this is thyroid, and it would really be hypothyroidism. So All of these are symptoms of hypothyroidism, and this elevated cholesterol is another sign that we're not processing fats in our energy sources quickly enough. And then finally, our 15-year-old presents with lateral flank bulge, meaning that there's not necessarily a hernia, but a bulge on the side. She also has facial hair. Hirsutism is the formation of facial hair in females when it should not happen. Hypoplastic uterus, meaning it's underdeveloped. Hypoplastic mammary glands, so the breast glands for milk are underdeveloped, and they show elevated levels of testosterone. So this is going to be our adrenal glands that control a lot of this. There's certainly going to be an element likely of, like if you said your gonads were part of it, that I would agree with that, but adrenals are going to be what's driving that one. All right, if you want to give yourself a little extra practice, this link will take you to an endocrine system quiz. So it has most, if not all, and more of the glands we talked about today. Then it has you match with the function. So this is a great way to practice kind of memorizing what hormones do what. Thanks for listening and have a good day.